So for tonight, I would like to focus on ICU patients and fungal infections in the ICU and specifically Candida. And now I would like to focus more on invasive candidiasis and candidemia. So if you do prevalence studies in the ICU, and this is the large European prevalence, point prevalence study, EPIC or EPIC-2, you will find reports on quite a lot of Candida infections. Now, we are not sure whether these are really invasive infections or whether these patients are just colonized. That's also always the issue, especially with Candida infections. But nevertheless, this means that intensivists encounter positive cultures quite often. And if we focus on bloodstream pathogens, so patients with positive blood cultures, growing Candida is not a good sign in terms of prognosis. The mortality, the crude mortality associated with it is very high and is higher than for the other bloodstream isolates. This is, of course, in part due to the underlying disease of the patient. Not every patient gets a candidemia. These patients may die from their underlying disease, but the bottom line is that once you get a report from the lab of a Candida growing in, from the blood culture, you're in trouble because the patient has a chance of 30 to 40% of dying unless you work very hard. And I'll show you that we will be able to reduce the mortality rates to, let's say, the 20% range. If we talk a little bit about the pathogenesis, it's good to notice that, first of all, Candida almost always comes in via the gut. Not via the catheter in most cases, but via the gut, colonizing the gut, especially if patients are on broad-spectrum antibiotics. And then either when surgery is performed and there is a suture which may be leaky, or just through the intact gut by translocation, Candida can get out of the gut and either cause a peritonitis or get into the bloodstream and cause a candidemia. So Candida colonizing the gut most often is the source of invasive candidiasis. So what about the catheter then? If it's not the source of Candida, what is its role? Well, whenever the Candida circulates in the circulation, it may seed upon the catheter tip and from there recirculate and go round and round until you pull the catheter. So it doesn't originate from the catheter tip, but the catheter will maintain the candidemia until it's removed. So how can we reduce mortality in patients with candidemia? These are a number of retrospective studies suggesting that early appropriate treatment is very important. Usually when you wait until you get the blood culture result, which will be 48 to 72 hours, you will see in all these studies the mortality rates around 30 to 40%. And these were not randomized studies, but just observational. Patients who for some reason received their antifungal therapy before the blood culture results were known, so within 24 or 48 hours after the onset of their sepsis, appeared to do better with lower mortality rates. Now, there haven't been any prospective studies proving this concept, but it seems very reasonable that once a patient has a sepsis due to Candida, early appropriate treatment will reduce the mortality. So the other question, and we addressed this already in the morning session, is whether we can prophylax Candida or we can detect Candida early in the ICU. And this is a study that was briefly mentioned where this is the most recent prophylaxis study, randomizing patients between caspofungin and placebo. And these investigators used this very complex predictive model to try to identify patients in the ICU at the highest risk of acquiring invasive candidiasis. But even when they applied this model to select patients for inclusion into this trial, there was no difference between the two arms. Caspofungin showed a trend to reducing the incidence of invasive candidiasis, but it was not significant. And the mortality rate was very similar in the two, and the length of stay was also similar in the two arms. So also with one of the newer drugs with a very sophisticated selection model, no effect of prophylaxis in high-risk ICU patients. And you saw this slide before. None of the studies actually has shown a reduction in mortality. So there is very little support for prophylaxis other than liver transplant patients and the other ones that we have discussed earlier. Candida score, you now know, is sometimes helpful, but mostly not. We got a question, how about the definition of sepsis? As you may know, there are new definitions of sepsis that have been released earlier this year. The term severe sepsis doesn't exist anymore, but for your judgment of the patient and his or her risk of having an invasive candidiasis, of course, nothing changes. You will acknowledge that patients who have septic shock, low blood pressure, organ failure are the ones who are most severely ill and are at risk. And we discussed the other risk factors that were applicable in Spain in this population with a reported high sensitivity and specificity, but not in at other sites. So the main message is that this is very interesting, but it's not universally applicable, and it should really be your local epidemiology which would guide your local guidelines. So you should know how many positive cultures you have had in the past few years, whether candidiasis is a big issue or not, and if the numbers are high, the culture-proven incidence is high, you may adapt your local guideline to tend to use empirical therapy. And then the way of deciding is always restricted to the patients with severe sepsis, and then use your judgment and your local epidemiology to guide this. If we go a bit more specifically to the guidelines and their application in the ICU, two guidelines, IDSA and ESCMID. We have heard from the survey that the IDSA guideline is most popular in this part of the world, which now also favors an echinocandin as primary therapy for most of the patients. And the ESCMID guideline is very similar, where actually fluconazole is very low on the list, got only a C recommendation, and so that differs from the IDSA guideline, but basically, and as you have seen, that was based on this large study where fluconazole did really perform poorly. If we now look at the results of this study in the ICU related to Apache 2 scores, this may be an easy graph for intensivists, and for other physicians it may be a little bit more difficult to understand. These are the two. This is the average success rate of patients randomized to anidilafungin, and this for patients randomized to fluconazole, stratified by Apache 2 scores. So all patients who had an Apache 2 score of 20 and were randomized to fluconazole had an average success rate of, let's say, 40%, and those who were randomized to anidilafungin had an average success rate of, let's say, 70%. So, and what you see then is that in this area where patients were moderately to severely ill in the ICU, the difference was really large. What you also see is that the slope is downward, which is what you expect because Apache 2 scores were designed to predict poor prognosis. But there is a consistent difference between the two study arms, especially in this area of moderately to severely ill patients. And that's why the IDSA in their former guidelines, the previous guidelines in 2009, recommended an echinocandin for this group with moderate to severe illness, whereas leaving it open what to do with the patients who were less severely ill. And actually this graph was the basis of the IDSA guideline, this particular graph from this trial. And you can also see that there is not really a cutoff. So the question, what does it exactly mean, moderately severe illness? Nobody can tell you because it's a continuous slope and there is no real cutoff. But how about these patients? Consistently also in the patients with very low to zero Apache 2 scores, there is a consistent difference favoring the echinocandin. And exactly this thought has prompted the IDSA in 2016 to recommend an echinocandin for all patients. So how do these drugs perform in ICU patients? We have seen a number of studies with ICU patient subgroup analyses. These are all the randomized studies comparing two different antifungals in patients with invasive candidiasis or candidemia. And the subgroups of ICU patients were analyzed and published separately with these results. And what you see is that fluconazole and conventional amphotericin B were associated with not so favorable results, whereas the three echinocandins and liposomal ampho B had success rates in the range of 65 to 70%, which is, I think, very favorable in ICU patients. One study has specifically focused on ICU patients. That was the anidulafungin study, which was open label, so non-comparative, specifically in ICU patients with additional risk factors such as abdominal surgery, cancer, renal insufficiency, hepatic failure, and transplant recipients. And this was done required by the European Registration Agency to collect additional data on specifically these high-risk patients. And I won't show you all the results of the trial, but just the success rates, which were, again, in the 60, 70, or 70+% range for all these subgroups. Just neutropenia was a little bit less favorable, and these were very, very low numbers of patients. So basically, again, success rates around 70%, which I think for the ICU is very favorable. How about the sickest patients, the patients with septic shock? There haven't been prospective trials in this group, but there has been a large cohort study on patients with Candida septic shock and positive blood cultures. This is a retrospective study, and what they basically did is a case control study comparing the survivors with the ones who died. And what you see is, that once you have a Candida septic shock, mortality rate is 70%, is very, very high. Some patients were treated by the physician with an echinocandin, others with fluconazole, voriconazole, or amphotericin B. And if you do the multivariate analysis, 3 factors came up predicting a beneficial outcome: early treatment of septic shock within 24 hours, adequate source control, which basically in patients with candidemia means pulling the catheter, and prescription of any of the echinocandins as opposed to fluconazole, voriconazole, or amphotericin B. So again, the 3 items that we see come back every time in patients with candidemia or invasive candidiasis: treat early, remove the catheter, and start with an echinocandin. Now, abdominal candidiasis is a very difficult area in ICU patients, and probably we have always underdiagnosed abdominal candidiasis. This is a very recent large survey from Pittsburgh, where actually there were as many patients with abdominal candidiasis as there were in patients with positive blood cultures with candidemia. So this is what they call the missing 50%. Only 50% were candidemia, and the other 50% were suggested in this center to have abdominal candidiasis. And if we look at the presentation and the risk factors, I won't go through the entire table, but what you see is that the major source is GI leak or GI surgery with or without abscesses. And the other area, of course, is pancreatitis, pancreatic abscess, pancreatic necrosis. Also, it's important to notice that mortality is around 30%, so a very high mortality rate. And these patients mostly have negative blood cultures. Only very few have positive blood cultures while having abdominal candidiasis, so taking blood cultures is not a way to diagnose this disease. How should we diagnose abdominal candidiasis? We should try to discriminate colonization of the wound or the drains from invasive infection. So this is quite a common consensus statement on the diagnosis. So growth or microscopy from specimens obtained during surgery or percutaneous aspiration. Of course, Candida growth from bile or removed devices during surgery. Candida growth from blood cultures in patients with peritonitis is, of course, suggested, or growth from newly inserted drains. So if you puncture, you place a drain, and then you do an aspirate, of course, that is not colonization, but real infection from the deep, but not Candida growth from drains that have been in place, and neither growth from wound swabs or exudates. So no need to take these samples because they won't classify for abdominal infection. If you look at mortality rates or survival, in this case, there is a difference between the patients with the abscess who have a quite favorable survival rate and the ones with peritonitis, most of whom die. And of course, again, that's because one can drain an abscess. So if you do a multivariate analysis on the predictors of mortality, of course, advanced age will predict mortality. Organ transplant recipients don't do well. The ones with abscesses do well. They have only a 25% chance of dying as opposed to the other groups, because you can do source control. And of course, early antifungal therapy, again, will improve the prognosis. So again, in this multivariate analysis, the same three factors that come up. So let's talk now a little bit about the non-albicans Candida species. We have seen a number of studies on the use of echinocandins in non-albicans candidemia in ICU patients. These are the collected or the pooled data from all studies that have been done with caspofungin. And what you see actually is that the success rates are very similar for all the Candida species, and we have quite some numbers of non-albicans isolates here, and all in the 70% range. And also, as we discussed earlier, success rates with Candida parasilosis are quite reasonable, although we would still favor an azole. The same has been done with anidilafungin. and we have pooled all the data obtained in prospective trials using enidlifungin, and now we have quite large numbers of patients with all these isolates. And again, if you compare that with the original New England Journal of Medicine trial comparing enidlifungin to fluconazole, the outcomes are very consistent and similar, but now the numbers of isolates are much higher. And there were no Candida krusei patients in that randomized trial because they could not be randomized to fluconazole, which is not active to Candida krusei. So now for krusei, we also know that the outcomes are quite favorable. Neutropenic patients have never been studied separately in prospective studies in terms of candidemia or invasive candidiasis. So all the data there are derived from subgroups of neutropenic patients in the large trials. And as you see, these numbers are very small, actually. These are the very recent data on enidlifungin in patients with neutropenia. 57% success rates, which is very reasonable in this group. Of course, if you have persistent neutropenia, outcome will be worse as opposed to resolving your neutropenia. Mortality was relatively low in this cohort, and with these data, the FDA has now also licensed enidlifungin for neutropenic patients. And this compares very well to the other drugs who all have studied subgroups of patients who were neutropenic while having their candidemia. And the general picture would be that conventional amphotericin B may be not that favorable, but results with the other echinocandins and liposomal amphotericin B are very, very reasonable. Now that we have 3 echinocandins, and I realize that may differ in various countries, but which one should we choose? And I must say there is not a clear preference in the guidelines, neither in the US nor in the European guidelines, because the drugs are basically very, very similar. As you heard earlier, there are small differences in the pharmacokinetics or the breakdown between the drugs. All 3 are degraded in the bloodstream, which is a very interesting mechanism, which is quite particular for echinocandins. Micafungin uses some hepatic metabolism, caspofungin somewhat more, and a little bit of renal elimination, and that is reflected by the interactions and the side effects. As you can see, there may be weak CYP3A4 interactions. Caspofungin requires some dose adjustments and has potential interactions with these drugs, whereas the other 2, and especially enidlifungin, have fewer interactions. So there might be a little advantage here, especially for patients who have hepatic dysfunction or are on any of these drugs. And then, which was also touched upon, there are a number of patients who should not receive an echinocandin because tissue penetration here is the issue. And we have been very pleased with the azoles, especially fluconazole, which has excellent pharmacokinetics, which gets into the brain, gets into the eye, and fluconazole gets well into the urinary tract. And that is not the case. These are the weak spots for the echinocandins. They hardly get into the CNS or in the eye, and they are not excreted into the urine. Now, the good news is that in all the large candidemia, candidiasis studies, we haven't seen breakthrough endophthalmitis patients, or very few, or renal candidiasis breakthroughs. So probably their pharmacokinetics are just favorable enough to prevent these kind of complications. But once you would have a patient with a brain abscess or an endophthalmitis or a lower urinary tract infection with fungal balls, which would require treatment, you would stay away from the echinocandin. So patients with endophthalmitis, for instance, should be switched to an azole. The final question is then, can we use these expensive echinocandins for a short period of time and then step down to an azole and preferably fluconazole? So there has been one trial focusing on this question. It was not a randomized trial between early step down and continuation on fluconazole, but this was the study where patients were allowed or encouraged to be stepped down as soon as after 5 days of anidilafungin. Of course, they had to tolerate oral therapy. They had to have defervest in this study. They had to be hemodynamically stable. I think that's the most important criterion, not neutropenic, and have documented clearance of Candida from the bloodstream. What does that mean? That means that on day 1 or 2 into therapy, you take follow-up blood cultures on echinocandin therapy, and if they haven't grown Candida on day 5 or so then they have been in the lab for at least 3 days, I would feel safe to switch to an azole if the patient is stable. Now, this doesn't really, of course, tell you that the cultures will really remain negative, but it's a good indicator, and if they come back positive, I would keep the patient on an echinocandin. So a large proportion of the patients, about 1/3 of these patients, were switched down by their attending physician to early fluconazole, and they did very well. They had a very high success rate. They had an extremely low mortality rate. Of course, this was not randomized, so these patients were stepped down. Even if they were in the ICU, they were stepped down to IV or oral fluconazole. Of course, this is a selected group who did well. And so the bottom line is, if you think a patient can be stepped down, he probably can be stepped down, and it's safe, and he will get well and survive. So this is really a paradigm shift. Now, the susceptibility or the species identification is not our driver of stepping down. We want to keep the patients for a few days on the echinocandin because of its superiority, and then if the isolate is likely susceptible and the patient fulfills these criteria we discussed, we will step down to an azole. So that would be my 4th rule then: treat early, remove the catheter, start patients on an echinocandin, and then step down once they have stabilized and they fulfill the other criteria. So in summary, we've seen that the intestinal colonization is the source of most candidemias. So that should direct our diagnostics and our empirical therapy. The early and accurate diagnosis is crucial also for abdominal candidiasis. We have seen that echinocandins are superior in most of the patients, and especially in the ICU, and that's why they have now been prioritized as the first choice. Success rates for Candida parasilosis are reasonable, and so this wouldn't preclude my first choice of an echinocandin, and a rapid step down in patients who have been stabilized is feasible after they have stabilized and their follow-up culture seems to remain negative. So I'll stop here, and I think we have questions after the second talk. Thank you.